Sadini Karunarathna, consultant anesthetist with special training in pain medicine at Apeksha Hospital Maharagama, to deliver her speech on pain management in pancreatic cancer.
Thank you for the kind introduction, and I must first of all wish my congratulations Professor Samadhi for being the first orator. And thank you for the Palliative Care College for giving me the opportunity to address this forum. So pain management in pancreatic cancer. So any cancer pain management is somewhat challenging. Towards the end of the disease, or towards the palliative pathway, the cancer pain management becomes more challenging and more advanced. There are many reasons for that, and out of all patients, pancreatic cancer patients is a special group of patients we encounter because of many reasons. One thing is they are having severe pain, and they are having a lot of anatomical and physiological derangements. So because of that, our interventions are limited. So I'm going to talk. My presentation is mainly about pathophysiology of pain in pancreatic cancer and management options. So if you talk about pathophysiology, it's complex, it's multifactorial, because there are many mechanisms in pancreatic cancer pain. One is pancreatic neuropathy, other thing is pancreatic duct obstruction. So Dr. Ranga well explained how the pancreatic ducts get obstructed. So the patient present with abdominal pain initially even. So when the disease gets advanced, these obstructions are more and patients get more pain. And direct invasion of adjacent structures, because there are so many important structures around the pancreas, so they get obstructed or compressed, and they can give a lot of visceral pain. And distant mets and side effects of treatment, including chemotherapy, radiation. Excuse me. This slide and this one is not compatible. Yeah. No. First. No. Go on. Previous one. Yeah. But these slides are not moving, is it? This is not the one I'm seeing in the screen. Yeah. Sorry, the slide I'm seeing is not the one in the screen. So it's, as I said, it's multifactorial and many mechanisms, and side effects of treatment, including chemotherapy, radiation, and surgery, will add more pain to the initial cancer pain. So when you are managing these patients, we have to address all these aspects. So pancreatic neuropathy is that direct infiltration of the tumor cells and cause inflammation of the surrounding nerves. And again, perineural invasion or malignant involvement of the protective sheath of bundles of axons, because celiac plexus and all are very close vicinity to the tumor. So therefore these patients having a lot of neuropathic pain. So in 70% of pancreatic adenocarcinomas, they present us with this neuropathic pain. And the malignant involvement of both intrahepatic and extrahepatic nerve plexus will cause enormous pain. And again, they can have increased nerve density and nerve hypertrophy. So that abnormal innervation of tumor will cause more intense signals to the brain. Not only the nerves, they secrete lot of neurotransmitters. Glutamate, substance P, nerve growth factor, which is a calcitonin gene related peptide, and inflammatory cells. All these neurotransmitters will abnormally fire your free nerve endings. So they invade nerves, and more than that, they secrete a lot of neurotransmitters which will cause firing of the nerve fibers. So we can imagine how the patients will present with pain, right? And pancreatic duct obstruction is the occlusion of the main pancreatic duct, and it causes increase in upstream intraductal and interstitial pressure, and exocrine enzyme deficiency with the resection of tumor and also affecting the exocrine part of the pancreas, both can cause enzyme deficiency. And malabsorption, especially postprandial pain, is a very significant complaint of these patients. And direct invasion of adjacent structures, as I said earlier, and chemo-related pain are the main mechanisms. So as any other pain condition, pain assessment is very important. Pain history, examination and investigation. Because pain history will reveal how the severity, mostly these patients are in severe pain category. In the pain score, they are around 7, 8, 9 or 10. Most of the time they are in the 9 or 10 region of the pain assessment scale. And if you examine, they are with a lot of tenderness, lot of back pain, sometimes muscle spasms, and sometimes with ascites and all the other complications will attribute to the pain some more. So we do investigations. One thing is to find the extension of the disease, because these patients liver dearrangements, sepsis, peritonitis, so many complications. And in addition, they are having a lot of nutritional deficiencies. So they are very hypoalbuminemic, so they are very cachectic, and a lot of sometimes with coagulation problems. So we have to do investigations for those things when you are managing these patients. And management is again highly individualized. Any cancer pain patient, management is highly individualized, because the patient's physiology is different, anatomy is different. Same cancer, but the two patients are different. So we cannot treat equally in any cancer patient, and their sometimes their expectations, their the other factors like their requirements are different. So any cancer patient is highly individualized. And as in any cancer patient, we are using both pharmacological and non-pharmacological measures equally in these patient management. So pharmacologically, we use analgesics, chemotherapy, and because multi-agent chemotherapy plays a crucial role, and enzyme replacement therapy, because they are having enzyme deficiency because of the cancer and because of the surgery, as Ranga said. So if we can replace their enzymes, it will help for the relief of postprandial pain mainly. But I don't think it is available for us. And interventions. So pancreatic ductal stenting, which will relieve the backward pressure, and pain management interventions are the mainstay of interventions we are practicing at the moment, and non-pharmacological measures as well. So analgesics, if we talk, we always use the pain ladder in this cancer as well, but there are a lot of limitations when you are using pain drugs. Even simple analgesics can be used, but one thing is that is not solely it is not effective at all, because these patients are having severe pain, and the liver impairment, kidney injury, gastric irritation, those things will limit the use. Even simple analgesics, paracetamol, NSAID, we are finding it difficult to use in these patients. So the mainstay of treatment, or the main drug we are using, is opioids. We know weak opioids are there, and strong opioids, but as these patients are in high intensity of pain, we use strong opioids straight away. You know that opioids bind to mu receptors, but they have different response, because their response is not equal, and it can cause it also act via inhibiting GABA release from periaqueductal gray matter. So opioid has several mechanisms of action. Anyway, it is the mainstay in the treating of pancreatic cancer. So we have fentanyl patches. It is a transdermal patch. You know, strong opioids, we are using mainly fentanyl and morphine. Fentanyl patches are available. There's a scarcity, but it is available. So one thing is that it doesn't cause much histamine release, so hemodynamic instability is minimum, and patients it is 100 times potent than morphine, so it will give a very good pain relief. So if you apply a one patch, we can keep it is adequate for 3 days. It works for 72 hours. There are several strengths, 25 or 50. We can sometimes apply 2 together, making it 75 or 100. So anyway, in each hour it will deliver the given amount. So it is very effective. Other thing is oral morphine, because most patients are in palliative care, they are at home or in the centers, not in the hospital. In that case, the main option we have is the oral morphine. So we use slow release morphine, that is SR morphine, which acts 12 hours, and immediate relief morphine. It is acting very quickly, like half an hour onset of action, and it will last for 4 hours. So these patients are having breakthrough pain. For that we are using IR morphine. And morphine patient control analgesia, or fentanyl patient control analgesia, is the other option we are having, and we are practicing it at Maharagama. So that is the gold standard of management, because the patient can manage his or her pain by himself, by the patient. There's a computerized software in the machine. It will deliver the adjusted bolus with a lockout time, that then the patient cannot take more than the limited dose. They cannot exceed the limited dose. So it will be very safe, and patient will not get overdose, and patient is not get underdosed either. So because of that, the PCA is the gold standard of treatment. The only problem is patient has to be in the ward. There are portable machines and there are portable options that patient can take home. We hope I wish if we can have some. There are, but the problem is the cost, because the bags and the pump and the counter, we don't know whether the pump will come back. So that there are issues like that, but there are options. The patient can take them home and use and come for the refilling. So that is the opioids if you are using, but again the liver derangement and renal impairment will limit the usage. And anticonvulsants, because these patients are having anticonvulsants and antidepressants are the adjuvant drugs. Because these patients are having lot of neuropathic element, these drugs are very useful. Gabapentin, pregabalin, and antidepressants like amitriptyline, duloxetine, venlafaxine. These drugs are commonly used as adjuvants, and this is useful to reduce neuropathic pain as well as to reduce the morphine requirement because they have the morphine sparing effect. But again, it is difficult to use in some patients. They are drowsy, they are liver derangement, sometimes they are in liver failure. In these occasions, the usage is limited. That's why I said the pancreatic patient is the most challenging patient cohort we are getting for pain management. An NMDA receptor agonist, ketamine and amantadine in low doses. This drug is we are using widely at the moment because we are short of fentanyl patches. No morphine SR some days, no IR, no gabapentin of any strength. So we are left with only ketamine and lignocaine. So we get down the patients and we admit, sometimes we keep them in the nearby hospice or somewhere and get them down for ketamine, lignocaine together infusions or single agent, but they are responding well. So that is the only drug at the moment we are having without a problem because of the shortage of supply of drugs. Fentanyl patches, they are very limited. No fentanyl patches from after last March to the country. So I'm finding with a lot of problems. I'm struggling with patients and I'm struggling with the ministry as well to get those drugs. So the ketamine is the saver of the patient and ourselves as well. But only thing is that we cannot give it to take home as IV, or there's no way to deliver it like that. But patient can get sublingual ketamine. That is the option if they are in far distance places or at home. So we are giving same dose sublingually, 4 hourly. The patient can take it. Alpha 2 agonist, very good analgesic agent, but it is not very much available. Sometimes we are having dexmedetomidine and clonidine, but they are very, very good adjuvants. The only thing is the short supply most of the time. So there are novel agents, though we talk these things, tapentadol and those things, it is not available. And cannabis, I think it's a good option if you can have. I think it is, they are not in the hospital but outside the hospital most of the time, but if we can get a thing, because one day I got a patient who is a cannabis abuser. I said, no, you cannot have, you haven't had good cannabis, that's why you are in pain. So the ward refused to give morphine and all that because he's a cannabis abuser, but I said, if you have cannabis, use it, because we don't have morphine. Because, and it is not cannabis, otherwise he is not in, he must not have that much of pain. So it acts via cannabis 1 and cannabis 2 receptors, and it inhibits inflammatory mediators and suppress chemo-induced pain. So the other thing is interventions. We are doing celia plexus in our unit. You know the anatomy, it is anterior to the diaphragmatic crura and posterior to the stomach, and it's comprising complex network in the interconnected nerve, fibers and ganglia. So I'm not going more detail about along this anatomy. but it has there are clusters of nerves and at the level of L1 vertebra. So it's visceral pain arise from the structures of celiac ganglion, and which then sends the signals to the splanchnic nerves, right? So if you block the celiac ganglia, you can cut off a lot of signals going through the splanchnic nerves. So the pain relief will last for 3 to 6 months. We are using bupivacaine and dexamethasone at the moment, and radiofrequency ablations are possible, and you can do alcohol injection and phenol injections as well to neurolysis. So celiac plexus, there are several approaches, posterior and anterior. The commonly used posterior approach, and it is through at the level of 12th rib, and we are going towards the L1 vertebra. We do it under fluoroscopy guided or ultrasound guided. Ultrasound guided is from anterior approach, but there are a lot of structures, important structures surrounded, so it is not easy, and it is very can be a very hazardous thing, because these patients are coagulopathic and they are having a lot of ascites. We cannot position them prone, so for this one we need prone position, which is very, very difficult in these patients with a lot of distension and pain. We cannot prone, but that is the safest approach practically, I see. So we do fluoroscopy guided injections. This is what we expect to see, spread of the local anesthetic as a sausage at the level of L1 vertebra. And the other thing is we do anteriorly, ultrasound guided. We look for the seagull sign, that is the hepatic artery and splenic artery dividing from the celiac artery. So it's like a seagull. So we don't see seagulls in our patients, because after surgery and after the tumor infiltration, the whole tumor is there. So the book says there are seagulls, but no seagulls at Maharagama at any time. So we go blindly. So that is why I said, and just below that is the aorta. So we pray and inject. That's the only thing that we can do in those patients. But so far nothing has happened. We have done. Mahesh is there to through that. So we are doing it, and either fluoroscopically or ultrasonically. So it gives good pain relief for 3 to 6 months at least. So there are complications, like immediately they can have low blood pressure because your sympathetic trunk is blocked, and bleeding is a major problem because coagulopathy and the major vessels we are very close to the aorta, and damage to the adjacent structures, including the spinal cord, because the artery of Adam-Kivik is just near that, and it can cause damage, or so it can cause necrosis of the spinal cord. Patient will end up in paralysis. So, and diarrhea is a common complication, and the spinal cord ischemia, as I said earlier. So there are problems with celiac plexus block, but that is the only options we have to give adequate pain relief. Epidurals are sometimes possible, but again the coagulopathy, sepsis may not allow us to do epidurals. So transhiatal bilateral splenectomy and bilateral thoracoscopic splenicectomy is a surgical options to relieve pain. So non-pharmacologically, the cognitive behavioral therapy, mindfulness, meditation, and TENS are the things we are having at the moment. And especially these patients, they are very depressed, they are having a lot of psychosocial issues. So cognitive behavioral therapy and counseling the patient and the family both parties are very, very important in the patient management. So cancer pain management is a holistic approach. We have to treat the total pain as well as we have to consider the whole family together. So in that sense, it is very essential to have the other people support. So that is what basically we are having at the moment for pancreatic cancer pain management. Thank you.